All right, we'll transition now to non-exudative AMD. I'm Johanna Sutton, professor, interim chair, and residency program director at UMass Chan Medical School. And we have a very distinguished list of speakers this morning still. And the first one is Tiarnan Keenan. He'll be presenting the importance of the AREDS supplements in progression of geographic atrophy. Tiarnan?
Yeah, thank you so much to the organizers of the invitation to speak. So yeah, I was going to talk about potential importance of the AREDS2 supplements in GA growth. And I should say I have no financial interest to disclose. I've actually put the take-home message here towards the beginning. So, in summary, we find that for non-subfoveal GA specifically, the AREDS2 supplements slow GA growth, but they slow it specifically to the macular center point by as much as about 55%, in fact. And the work is now published and accepted in ophthalmology just a couple of months ago. If you wanted to read further, the reference is there. But just to go back towards the beginning, I think we've known for a long time that AREDS2 supplements decrease the risk of progression to late AMD. But in terms of GA growth, I think we kind of assume they probably don't do a whole lot at that stage. But there were very few data actually looking at this in detail. The only one place looking at it just in passing really was a small part of this 2009 paper. It looked at the AREDS1 data set, but just a very small subset of individuals with GA. So there was no real power to say anything too meaningful. So I wanted to reopen this question with the full AREDS1 data set as well as the AREDS2 data set for the first time. So I looked at GA growth in fairly standard ways based on repeated measures regression analyses. But importantly, we're going to look at the GA growth rates and relate them back to the study randomizations in AREDS1 and AREDS2 because through those robust randomizations, we're justified in talking about causality and treatment effects. But I will mention, of course, these are post-hoc analyses. We have to bear that in mind. The other thing I wanted to emphasize is that, we're used to GA area as our normal metric, and I certainly analyzed according to area. But I think particularly for non-subfoveal GA, there's more to progression than area alone. And not all areas the same, I would say. So for non-subfoveal GA, we're also really interested in the kind of speed of progression specifically to the macular center point. That's crucial for final visual prognosis. And we know that's faster in some and slower than others with this kind of interesting but poorly understood phenomenon of foveal sparing, where growth in some people towards the center is slower, leading to donut, horseshoe configurations. And at those points, acuity is still typically really good. So I used the second complementary outcome measure to look at rate of progression to the center. A lot of information here, really just to emphasize that in AREDS1, we now had the full data set of GA, as many as about 400 eyes, all shown according to the randomization, mean follow-up about 3 years. And interestingly, when we look according to area, the traditional metric, we don't see any significant treatment effect in AREDS1 according to that randomization. But the interesting part comes when you focus on non-subfoveal GA, and you look at that rate of progression to the macular center point. And there suddenly we do see a significant treatment effect for the antioxidant randomization and moderately large effect of about 35% slower growth. Loads of other analyses in the paper I don't have time for. Moving on instead to AREDS2, I'm going to focus on the primary randomization that I think most people are familiar with. Essentially, we have even more eyes here. We have as many as about 1,200. Again, all the details of the characteristics according to the randomization. And mean follow-up here was about 3.5 years. It's kind of the same story. So again, if we look according to area, at that randomization, we don't see any significant treatment effects. But instead, focusing on non-subfoveal GA and looking at that rate of growth to the macular center point, suddenly we do see a treatment effect for lutein zeaxanthin. And again, it's moderately large at about 35%. And this treatment effect is actually on top of the previous one I mentioned because, of course, all of these individuals were also taking the AREDS1 antioxidant supplement. So just to pull out those two positive findings, they both related to non-subfoveal GA. We see a total effect for slowing growth to the macular center point of about 55%, coming partly from the AREDS1 antioxidants, partly from the AREDS2 lutein zeaxanthin, all of course contained in the modern AREDS2 supplement. I don't have too much time to talk about visual acuity, but we even saw some, I would say, suggestions of a benefit in terms of slower decline in BCVA, according to those same randomizations. We had very little expectation of seeing that really, because in most cases our follow-up stopped short of actual center point involvement. But that should mean, I'd say it's at least suggestive in the same direction. And then broadly, kind of interesting to think, how can there be a differential efficacy, whether we look for area versus growth to the center? But actually, it's not necessarily the case that these have to behave the same. And particularly if we consider the case for lutein zeaxanthin, we can imagine how they could actually behave really differently. So, at the top right of the diagram, we see in yellow that lutein zeaxanthin, of course, is really highly concentrated in many people, at least, at the central macula, but it's pretty much absent elsewhere. So to me, it seems reasonable that if it's going to slow growth, it's probably going to do that only at or near the center. It's not going to slow growth in the peripheral macula. But of course, the area metric is totally dominated by the peripheral and mid-peripheral macula, because that central area just occupies about 3% of the total macular area. So I think that's how you could have something doing an amazing job near the center, but that would be lost in the noise of a global area metric. So, I think potentially this extends the role of AREDS2 supplements later in the course of AMD. And I guess there are fewer reasons in some ways not to take it. Very low cost, very low burden to patients and physicians, excellent safety profile. We're used to these supplements. Interestingly, on the biological side also, I think this tells us something about foveal sparing. It suggests to me these molecules are actually important in that phenomenon of foveal sparing, but it seems you can kind of restore or even augment that natural phenomenon by simple oral supplementation. So as I say, potentially extending the role of these supplements later in AMD. Just some caveats to mention. As I said, these are post-hoc analyses. We're hoping to do a new dedicated trial as part of the AREDS3. They were based on color fundus photographs, being an older study. Actually, I don't think that makes too much difference for the reasons I've listed there, particularly the randomization. There are some limitations to proximity as a purely linear metric, which is what I used. But Amita Donald-Pali's team at Wisconsin have done full-scale regrading just very recently of all of the AREDS2 GA cases. So now we have these kind of contours. Instead of just area and proximity variables, we can do proper topographic and zonal analyses. Again, we find for non-subfoveal GA, these supplements slow growth to the center by about 55%, linked to foveal sparing. Thanks so much to the individuals listed here, and thank you to you for your attention. Appreciate it.
Thank you very much. We'll move on to the second talk by Sadda, and acquired vitelliform lesions, the forgotten deposit in AMD.
Thanks very much, Joanna. And thanks for the opportunity. These are my disclosures, though not really relevant for this presentation. So I think we're all very familiar with the traditional drusen-associated AMD phenotype and its progression to atrophy. But we also recognize that regular drusen aren't the only deposits in our patients with AMD. They can have cuticular drusen, certainly, but they can also have subretinal accumulations, such as subretinal drusenoid deposits, but also acquired vitelliform lesions, which is the topic of this presentation. Now, acquired vitelliform lesions have a very characteristic appearance on various multimodal imaging technologies. They are hyperfluorescent on autofluorescence imaging. They appear yellowish on color imaging typically. And on OCT, you see these hyperreflective subretinal accumulations, although they can appear hyporeflective as well. So just an example where you see a yellowish lesion on color, you see the subretinal accumulation. Of course, sometimes they can have areas of pigmentation, and they correspond to these sort of denser hyperreflectivity or cores within the accumulation. Now, they can occur as solitary lesions, and we think of them as part of AMD because we see them in the context of other features such as large drusen, SCD, cuticular drusen, and the like. But they can also be single or multiple, and it's important to keep in mind that they are distinct from SCD. Unlike SCD, these lesions are hyperfluorescent, so they're a different type of accumulation. So we had an opportunity to study this. It was a paper recently published in Ophthalmology Retina looking at over 1,000 patients with intermediate AMD. We were able to study acquired vitelliform lesions. And one of the take-home messages from this presentation is that these aren't uncommon. They were actually present in 14% of patients in an all-comers intermediate AMD population. And so in the analysis I'm going to show you, we compared the 217 eyes that we had with these acquired vitelliform lesions against age-matched and sex-matched control eyes from the same cohort. So we looked at a whole bunch of different features, associated features with these lesions, such as the presence of SCD, hyperflective foci, and the like. But we also looked at pachyvessels. And you might say, wait a minute, pachyvessels, you're talking about AMD. But it turns out that eyes with AMD certainly can have dilated choroidal veins, even though they may have typical features, including regular drusen. We also looked at quantitative characteristics of the lesions, of the acquired vitelliform lesions, including their height and width and the proximity to the foveal center. So in comparing the case and control groups, again, a busy slide, I apologize, but one of the things I want to highlight is that eyes with AVLs, they tended to have slightly thicker choroids, and they did have a higher frequency of pachyvessels, as you can appreciate, and a little lower frequency of SCD, interestingly. Again, a lot of numbers here in terms of the actual quantitative characteristics of the acquired vitelliform lesions themselves, but I'll give you the take home. Really what we found were that acquired vitelliform lesions, again, you can have multiple in the same eye, but those under the foveal center seem to be taller and wider. Now, what happens to these lesions over time? Because that's actually the real important message, I think. And we know from previous work, this is a nice paper from Chandrakumar Balaratnasingham and Bailey Freund and colleagues, and they showed this biphasic sort of life cycle where the lesions grow and then they go away, and usually it takes 2.5 years before you get to that break point. And importantly, it's in that sort of downward phase when bad things happen that these patients can develop macular neovascularization as well as atrophy. So we were very interested in studying that as well. So 75% of the eyes with AVLs in our cohort actually had 2 years of follow-up. And 2 years, I think, is very important because in many clinical trials, that's obviously the time horizon that we look at. And so this is the companion paper in that same issue of Ophthalmology Retina. And we classified patients into, with these AVLs over time into 6 categories based on the outcome at 2 years. Some, as you see here, remained relatively stable, about a quarter of them. Some actually increased in size. Others decreased. Some actually disappeared completely with a reappearance of the outer retinal bands, and some actually collapsed with a loss of the outer retinal bands and the development of atrophy. Now, at 2 years, we had a very low incidence of macular neovascularization, so I'm not going to say much more about that in this particular study. We did then look to see what were differences amongst these different outcomes at 2 years. And in particular, we're interested in that collapse group that progressed to atrophy. That was obviously an outcome of concern. And again, a lot of numbers here, but I will highlight that the eyes that with AVLs that collapsed, those lesions were taller and wider. That was a key takeaway from that. We also then looked at what are predictors for the development of atrophy within 2 years of presentation of these, or of identification of these AVLs? And basically what you can see in the multivariable analysis, the two that really stand out, certainly the height. So lesions that are taller were more likely to progress to atrophy. And even though I said that eyes with AVLs less frequently had SCD compared to intermediate AMD eyes without AVLs, the presence of SCD in those eyes was associated with a higher probability of progression to atrophy within 2 years. So to summarize, acquired vitelliform lesions should be considered part of the expanded phenotype of AMD as they're associated with other typical AMD lesions, and they can progress to macular neovascularization and atrophy in the region of the lesion. Now, I do think it's interesting that these eyes seem to have an increased prevalence of pachyvessels that may provide some insights into the pathophysiology, as we certainly can see vitelliform lesions in pachychoroid or venous overload choroidopathy diseases. But the critical and most important take-home message is that these are not uncommon lesions, and they're present in 14% of our patients if you look for them. A very characteristic multimodal imaging appearance that's distinct from subretinal drusenoid deposits. And of course, the most important thing is that they have a biphasic life cycle where they grow and then they recede. And in that receding phase is when we need to be most concerned, because that's when these patients can progress to atrophy as well as develop neovascularization. And potentially, if you see a patient you're following with intermediate AMD and you're seeing this type of regression, perhaps they should be monitored more frequently, because again, this is where those complications can appear. So I want to acknowledge the members of our lab as well as our collaborators who we were able to work with on this project, in particular Charlie Wyckoff, who provided the cohort that we studied in this analysis, and thanks very much for your attention.
Next talk is multimodal differential diagnosis of macular atrophy, to be presented by Giovanni Staurenghi.
Good morning, dear moderator, dear colleagues. First of all, I would like to thank the organizing committee for the kind invitation. This is my financial disclosure. When we look at patients with geographic atrophy, we have to think that macular atrophies can be related to other series of other disease. And OCT can actually detect early changes very well with atrophy, but unfortunately, probably alone is not able to doing a differential diagnosis. And also the autofluorescence corresponding with OCT are actually showing some differences, but also in this case, sometimes the appearance of the autofluorescence can be exactly the same for different diseases. So in my presentation, I will try to introduce some multimodality imaging approach for doing a differential diagnosis. Let's start with an easy one. The mitochondrial disease are always characterized in autofluorescence by this radial spike of hyperautofluorescence, and particular interesting the nasal part of the eye. And it's quite interesting because there is another disease that is malattia leventinese of the honeycomb retinal dystrophy that has the involvement on the nasal side. But in this case, the OCT can be useful to identifying a different type of deposition at the level of the RPE. Now, when we have such a situation with two autofluorescence that look similar, how we can differentiate the disease? And ICG can actually be helpful, showing a dark atrophy in a patient with a late onset Stargardt disease, or meanwhile in geographic atrophy, the area of atrophy has isofluorescence comparing with surrounding area. Now I try to explain why, if you have a late onset Stargardt disease and we actually take, the first part where the RP is still present, we have a quite normal autofluorescence. When we hyperfluorescence in ICG, then we actually have the edges of the atrophy that has still some fluorescence and then dark in the central part. Now, if we look at this cartoon, of course, the normal fluorescence from ICGA is actually related to the fact that we have RP, so the choriocapillary and the subtle layer. When, the more recent disappearance of the RPE, we still have some choriocapillary and subtle layer, but in the more advanced, the RP is gone and for more time, and choriocapillary and subtle layer disappear. This is not the same for age-related macular degeneration, where some RP cells, as demonstrated by histology, can be present in the area of atrophy and maintain a little bit of choriocapillary and subtle layer. And these features can be also observed with OCTA, and in particular with late onset Stargardt disease, we can actually see a huge other layer vessel denudated by the lack of subtle layer that instead we have in a geographic atrophy. Another case of dark atrophy in ICGA, late ICGA, is in central area choroidal dystrophy. ICGA can also be useful if we want to detect, the angioi streaks, also the small angioi streaks when we have atrophy related to the pseudoxanthoma elasticum. When we have reticular pseudodrusen, well, it's a little bit more difficult. How can we differentiate, for example, the extensive macular atrophy with pseudodrusen called EMAP, or the AMD with pseudodrusen? Now, the extensive macular atrophy as a younger subject, vertical distribution of atrophy, thicker choroid, and pavestone degeneration. In AMD, you actually have, and you can notice in that autofluorescent image, that you have not as dark as we expect, and this is related to the fact that the choroid is thin, and we actually get some fluorescence from the sclera. Last but not least, the medical history is also important. In fact, that could actually help us in identifying the potassium polysulfate maculopathy, as we saw this morning at least twice, and then the diadenosine maculopathy. So at the end, if we want to identify a patient with a geographic atrophy, we have to use a multimodal imaging approach, also with genetic and medical history. Thank you.
Thank you very much. The next talk is Key Biomarkers for Geographic Atrophy Progression, Impact on Patient Selection for Therapy by Frank Holz.
Thank you, Joanna. Dear colleagues, it's a great pleasure to contribute to this fabulous program of the Retina Subday. These are my disclosures. So we now have 2 positive phase 3 clinical trials on complement inhibitors that show a significant decrease in geographic expansion rate over time. Obviously, now we have to ask us, what are the best patients who would best qualify for initiating treatment in this disease state? So in terms of heterogeneity, it is known that there's a very high degree of intervitreal variability and of intravitreal symmetry, as just by eyeballing through this example of different patients. And this actually is reflected by the enormous variability in the progression rates of these patients. Here you see 3 examples, a so-called slow progressor who only grows about 1 square millimeter per year, then in the middle bit 2 square millimeter per year, and another one almost exploding at 5 square millimeters per year. So a huge variability that we have to take into account when we identify patients for intervention. Ultimately, we want to find those who are fast progressors and are at high risk for visual loss, and ultimately aiming to preserve central vision. Now, in the meantime, we have ample knowledge about markers. Some of those are lesion-specific markers that we can identify by imaging methods that do help us to sort out who is falling in the basket of a fast progressor rather than a slow progressor. And this is important, again, to identify patients at particularly high risk. And I will touch upon, in the next few slides, on some of these features. It's a peculiar biological phenomenon that these GA areas grow at a linear fashion. It is not well explained, and it's very uncommon in the human biology, but it is as it is. So if you have historical prior data on growth rates, you can already make it a call how this atrophy will progress in the future. Then this is worked together with Glenn Jaffe. Larger lesion sizes grow faster than smaller lesion, that is a given. And importantly, focality plays in. So if you have a unifocal lesion at baseline, it grows slower than a multifocal lesion, as shown here in these 2 time-lapse movies over a period of 3 years. Also, the primary location plays in. So if I have a foveal lesion to start with, that seems to be a slower kind of progression than if you had extrafoveal lesion to start with. And interestingly, the answer of and the retreatment response of complement inhibitory therapy has a larger effect size in these extrafoveal lesions as opposed to the foveal lesions. Then it's worthwhile looking into the pathway of GA development. We already saw Vas's brilliant picture on the Vitelliform lesions. And if you have, for example, here a collapsed large PED, that will leave you with a single spot of atrophy. And this type of atrophy typically has a very slow progression over time. Giovanni mentioned the toxic STDs, formerly known as reticular pseudotruths, and if those are present outside the atrophy, then it grows much faster, typically also associated then with a thinner choroid and, again, a very high progression rate. We already saw the autofluorescence, which not only is helpful to dissect mimicking diseases for late onset atrophy, but is also helpful in dissecting, again, slower from faster progressors. And if you look at the perilesional autofluorescence pattern, you have a clue on future progression rates, and the most fast progressor here is the so-called trickling type, and this is characterized by these lobular outer boundaries, also by STDs, thin choroid, and this grayish appearance of the atrophic zone, which is, and Giovanni just gave one possible explanation, another would be that there are massive basal laminar deposits which give rise to an increased autofluorescence signal. Now, as a surprise, the status of the fellow eye also is an important factor. So if you have bilateral GA, then your eye that you want to treat progresses faster. If you had in your fellow eye just MNV, it's a bit slower. And the slowest progression is if your fellow eye simply has early or intermediate AMD features. Now, when looking at photoreceptor degeneration, it turned out that we previously thought first the RPE goes, then the photoreceptor goes, and these analyses, AI-based, showed that you see here a thinning of the outer nuclear layer over time, and this is in areas of the border zone, so outside geographic atrophy, and so photoreceptor degeneration obviously does precede loss of retinal pigment epithelium, and this type of degeneration has turned out to be prognostic for future RPE atrophy progression. And this can also be influenced by complement inhibitory therapy in that this thinning of outer nuclear layer is actually slowed by intervening with these agents. Genetic factors, there's huge knowledge in the meantime, and we know about the risk variants on chromosome 1 and 10, but there's evidence for a role of genetics in the onset, in the development of AMD, but there's controversial data on the impact of GA progression over time. So currently and as of yet, there's no evidence for an association of the genotype with CI treatment response, and therefore it is not necessary to genotype your patients prior the start of complement inhibitory therapy. Now, sometimes there are also protective measures that have to be looked at. This was addressed in the morning session already. This is an atrophy that hardly grew at all over many years, and the reason here being that it was harboring a large non-exudative type 1 MNV between Bruch's membrane and retinal pigment epithelium. And we already discussed this morning that here the start of complement inhibitory therapy may be not helpful and may trigger that it converts into an exudative phenotype, which then would require additional anti-VEGF treatment. Of course, there are cases that we would not consider where you would go rather the route of watch and wait. If you have the small eccentric atrophic lesion, that is a patient you would not initiate treatment. But what we need in taking care of our patients are tools that help us of monitoring the progression and actually calculating the progression rates. That has been done in all clinical trials so far. And there are now AI-based algorithms based on OCT images that are helpful for monitoring, but also for predictive modeling of atrophy progression. And they are valuable tools. There are now many providers who offer such tools, and it will be helpful to ideally educate our patients that with treatment we see a deflection in the progression slope, so it's helpful to have a feedback. So to sum up, who are the best patients to treat? Obviously patients with the potential for rapid GA expansion, residual vision, central residual vision that is worth saving in these patients, ideally an extrafoveal location to save central vision, imaging available from prior visits, or these key markers for fast progression, and the fellow eye who has already visual loss from geographic atrophy, and finally a low risk for vasculitic inflammatory complications, as this has been seen in some of the trials. So, for example, no prior history of either uveitis or diseases indicating systemic immune dysregulations. Thank you very much.
And our next talk, treatments for geographic atrophy, 5 limitations to consider. Susan Bressler.
Thank you, Johanna, and to the meeting organizers for asking me to contribute. In the last 2 years, treatments for geographic atrophy have launched, and what I'd like to offer you today are 5 potential limitations to consider before recommending these treatments to our AMD patients. Due to time constraints, I'll concentrate on pegcetacoplan, but much of what I have to share is likely applicable to avicincaptad pegol as well. My financial disclosures are shown here. In February of 2023, the US FDA approved the very first treatment for geographic atrophy, and that was based on the Philly, Oaks, and Derby clinical trials primarily. 6 months later, they approved a second agent, avicincaptad pegol, based on the companion GATHER studies. But within 11 months of the US approval of pegcetacoplan, the European Medicines Agency, the regulatory body for Europe, refused marketing authorization for pegcetacoplan. And they remain committed to that decision in June of this year, following an appeal by the drug's developers. The EMA did conclude that the drug slowed the growth of GA lesions. However, they were very concerned that there was no clinically meaningful benefits for patients that impacted their everyday function. Moreover, they were also concerned about the new safety signals of an increase in incident exudative AMD, as well as intraocular inflammation. So in sum, this was a regulatory body that could not establish a positive balance of benefits and risks. So why might a regulatory agency come to these conclusions despite the enormous public health impact that we recognize GA associated with AMD has? And that brings us to our 5 limitations to consider. Number 1, every clinical trial, we focus on the completeness of follow-up. In this slowly progressive disease, Oaks on the left, Derby on the right, look at the rates at which patients dropped out of the study. It varies from 20% to as high as 32%. So it's concerning that we do not know the 2-year course in up to a third of the participants. In addition, it's concerning that there's a dissimilar rate of dropout through the 2-year time point. Notice it's the individuals who are randomly assigned to pegcetacoplan monthly that had the greatest probability of not completing the study. This imbalance of loss to follow-up may not necessarily be random, and so the statistical means by which we impute for missing values may be faulty and introduce bias into the study's outcomes. A third potential limitation pertains to the selection of the primary outcome, which was evaluating the average change in growth of the GA lesions in treated eyes versus sham. However, it was reviewed as a relative reduction in lesions that continued to expand. Certainly for the individuals who were treated every other month, there was a 17 to 18% reduction by 2 years relative to sham, and for those treated monthly, an 18 to 22% reduction relative to sham. That difference is at best a modest anatomic difference. And you see Derby on the right, at the actual primary outcome visit of 1 year, that treatment difference is even smaller. And that brings up the controversy of the selection of looking at a percent reduction in lesions growing as compared to concentrating on what the absolute difference is in the size of the growth between the treatment arms and the sham group. So using Oaks as an example, for those individuals using pegcetacoplan monthly, that relative decrease of a 21% in growth rate equates to a 0.4 square millimeter difference at 1 year. For individuals treated every other month, that relative decrease of 16% equates to an absolute difference of 0.3 square millimeters. And going out to the 2-year visit, no matter which trial, Oaks or Derby, no matter which dosing frequency of pegcetacoplan, the absolute difference in the growth is still less than 1 square millimeter. Fourth limitation is the finding that these anatomic treatment efficacy was not supported, emphasize not, by any of the pre-specified secondary outcomes intended to look at functional benefits. Here you see for visual acuity, over the course of 2 years, patients in sham, patients in active treatment are on average losing vision. And at 2 years, there is no signal that the treatment is associated with a preservation of vision in the total cohort. In addition to visual acuity, there are other pre-specified functional endpoints in this study, each of which failed to identify a functional difference, including maximum reading speed, functional reading independence index, and mean macular sensitivity. So, for our fifth and final potential limitation for consideration is patient safety. Here you see the rates of new onset exudative AMD in the study eyes at 2 years, and you see it is the individuals randomly assigned to pegcetacoplan that have the greater rate of having exudative AMD in a dose-dependent fashion, an outcome that can clearly ultimately adversely affect the vision outcomes in these individuals. And post-marketing, we're all aware of the emergence of cases of retinal vasculitis, the majority of which had an occlusive vasculopathy in the setting of significant intraocular inflammation and concomitant additional vision compromise, with the majority of patients losing 3 or more lines in association with this event, and a very sizable minority having severe vision loss, 6 or more lines of acuity, as well as the anatomic change of anterior segment neovascularization. So in summary, the good news, we have 2 treatments approved by the FDA to consider for patients with geographic atrophy. And approval of this has likely brought a humongous increase in scientific attention and funding to this important public health problem. But where are we right now? The not so good news is the limitations of the magnitude of the treatment difference, the incompleteness of follow-up and its potential non-random nature, and that's effect on our treatment outcomes, the lack of a functional outcome pre-specified to support the anatomic differences, and the new safety concerns that might ultimately affect vision. Hopefully, this will help you consider the role that these agents may or may not play in your practice. Thank you.
And our last talk, What's in the Pipeline for Dry AMD by Glenn Jaffe.
Thank you very much, Johanna. I'm very happy to be able to give this presentation. By way of disclosure, I've consulted for the listed companies as potentially relevant. So what's new in the dry AMD pipeline for 2024 and now coming up 2025? And in answer to that question, the short answer is that a lot is new. And just to define a couple of the terms we'll be using, intermediate AMD refers to large drusen that are at least 125 microns and or associated pigment. Late AMD is geographic atrophy that applies to non-neovascular AMD. The term geographic atrophy specifically for non-neovascular AMD, and as brought out beautifully by Giovanni, macular atrophy is the general term. So if you have neovascular AMD and secondary atrophy, that would be called macular atrophy, not geographic atrophy. So with that in mind, what's in the pipeline? As you've heard about throughout the meeting, there's been a shift towards biosimilars in general, but also towards non-neovascular AMD, and there's lots of dry AMD pipeline drugs. In a recent review, 70 companies described 80 different products, and this is a publication that comes out once a year with new pipeline drugs, and many of these were related to dry AMD or geographic atrophy particularly. And I could be here all day talking about all these, so I'm going to limit the discussion to those that are at least in phase 2 or greater. So what about intermediate AMD? There are intravitreal approaches and photobiomodulation. And one example of the intravitreal approach is with rizateginib, which is a synthetic RGD-like peptide, molecular weight less than a kilodalton, very small, rabbit half-life of 21 days. It's assessed in a phase 2 study, and it improves mitochondrial function. Here you see the primary study result. It met the endpoint of at least an 8-letter gain in visual acuity. A very promising therapy, photobiomodulation, is a non-invasive way of treating, and this uses multi-wavelengths, far red, near infrared, and far yellow. And the light that gets absorbed by photoreceptors, cytochrome C oxidase, that activates mitochondrial respiratory transport, initiating a signaling cascade, and this ultimately leads to cytoprotection. And this was demonstrated in a phase 3 LightSight 3 study that showed that by visual acuity measures, so both of these were functional outcomes, this and the previous one, the primary study outcome of visual acuity was met. And it also, interestingly, reduced geographic atrophy occurrence 24% in the sham compared to about 7% in the PBM group. And this is now sitting with the FDA for review. What about geographic atrophy? They can involve intravitreal injections, systemic treatment with subcutaneous or oral agents, or gene therapy. You've just heard about a variety of intravitreal injections, and complement has been key in the intravitreal injections, presuming that complement dysfunction is associated with geographic atrophy. So there's been multiple different agents targeting multiple different pathways. And as you saw, geographic atrophy growth rate has been typically the primary endpoint. And you just heard about the pegcetacoplan C3 inhibitor and avacincaptad-pegol C5 inhibitor. And you also just heard from Susan that the regulatory agencies in general like functional endpoints. And you just heard that pegcetacoplan's application was rejected by the EU because of a consideration that there was no meaningful functional endpoint. So I'm going to show you some examples of pipeline drugs. Some of these were successful, some of them not so successful, but interestingly, even though some of the pipeline drugs that did not meet their phase 2 endpoints generated enough information to inform a phase 3 study. And their structural and functional endpoints have been used depending on the study. So ANX07 is a C1q inhibitor thought to target neuronal synapses, so a different mechanism than C3 and C5 inhibition. This was tested in the phase 2 Archer study. The 12-month results showed only a 6% reduction in GA growth, but it did prevent a 3-line visual acuity loss. And you can see this whether it was foveal, which is on the left, or the non-foveal lesions with the reduction in the 3-line loss. And based on these results, this informed the phase 3 Archer 2 study, which was just initiated, and this is based on a functional endpoint, visual acuity. What about systemic therapy, subcutaneous or oral agents? This has been tested with the subcutaneous elimipritide injection. It's thought to stabilize mitochondria through cardiolipin. It did not meet the low luminance visual acuity endpoint or the geographic atrophy endpoint, but it did reduce ellipsoid zone attenuation. And on the left, you see total ellipsoid zone attenuation. On the right, you see partial attenuation. And so this also informed the phase 3 design, and this is being tested in the Renew and Regain studies, which have an ellipsoid zone endpoint. The presumption is that ellipsoid zone loss equals photoreceptor loss equals loss of function. Ionis is a company that had developed a very novel antisense oligonucleotide targeting factor B, tested as a subcutaneous delivery. Unfortunately, just recently missed the endpoint, and so this program has been halted. Another oral agent, factor D inhibitor, the danicopan, was tested in the phase 2 PRISM study, 3 doses compared to placebo, and the study readout is going to come very soon. Finally, with gene therapy, this has been tested as an example with the gyroscope study and Horizon phase 2, which was a subretinal injection to increase complement factor I as a protective mechanism. 2 doses tested compared to control. And this looked very promising. The asset was bought by Novartis for $800 million with milestone payments at $80 million. And in September of this last year, the Data Safety Monitoring Committee halted the studies because they felt the benefit was not greater than the risk. So this also the development's been halted. But to conclude though, as you can see, there is a robust pipeline and targeting multiple pathways, multiple delivery methods, and even when a phase 2 study might not meet its primary endpoint, it helps to retool for the phase 3 and we get different information on mechanism of action and maybe target something a little bit differently. So stay tuned, you're gonna actually hear readout from at least one of these studies very soon. Thank you very much.
Thank you very much, Glenn. Thank you very much to all of our excellent speakers in this session. We'll be moving on now to the panel and a non-exudative AMD panel discussion. Moderator will be Dr. Karl Csaky. Thank you.
All right. Well, welcome to this session on dry AMD panel. And I will be the moderator. My name is Karl Csaky. And today we really have a distinguished group of folks to really provide their thoughts and about various topics that we've heard already this morning as it relates to dry AMD. These are the disclosure slides. I'm just going to go through them quickly. just to show that, yes, several of us are working with GA companies, and these will be the topics that we'll be talking about as we go through this discussion. So we'll start with, the kind of backdrop, and really when we look back, it was really 2007 when I and others folks at the NEI, we ran a symposium, and we showed data that suggested that if you can reduce the expansion of GA, that would be an approvable endpoint, and that resulted in an agreement with the FDA, and then of course that was the basis for the approval of the 2 drugs that Susan just talked about. And of course, as she mentioned, one of the challenges is that the visual results have been a little bit more challenging in terms of trying to tease out what is the visual benefit in these patients who are receiving these drugs. And of course, we just saw the fact that the FDA approved, but the EMA did not. So we're going to start this good discussion. First, Joan, to you, all right? So we saw this discrepancy all throughout this meeting. We've seen kind of a little bit of differential thoughts, but I think it's important just to take a step back and say, a thought leader like yourself, what would you like to see if you were talking to companies? You heard Glenn talk about all these new drugs in development. Where would you like to see a good outcome that would get you kind of excited about a treatment for GA?
Well, thanks, Karl. Thanks for including me on the panel. And I guess like may not be what I'm thinking about, because I think once the FDA has used a strategy and drugs have been approved, most companies are going to be thinking that's where they're going to go after. So I think an anatomic effect on GA growth is likely to be with us for the near future at least. I think typically we would expect to see non-inferiority trials at this point. But interestingly, the FDA was unable to develop a significant non-inferiority margin, which kind of suggests that treatment and placebo are kind of the same. So that's sort of interesting in and of itself. But I think that we will be looking at GA growth. There are other anatomic markers like progression to the center, as we just heard again from Giovanni and others, which also may be interesting. But I think what I would like, I guess, along with these anatomic markers is some effect on visual function. And I think hopefully we will see more of that. Although the QCSF was not effective in the ONL studies, I think this QCSF, a new method of measuring contrast sensitivity, which gives us a lot more information, has some interesting metrics that really correlate both with GA growth and GA progression. And that would be worthwhile, as long as others that we're aware of, like low luminance visual acuity and reading speed and the like. So I think those are going to be important. And of course, keeping aware of safety issues, as Susan just reminded us.
Great. Robyn, the FDA in Australia has not made a decision yet. If you were giving them advice, what is your thinking about what you've seen with the data, and what are your thoughts about what these present treatments provide?
Thanks, Karl. So I think it's quite clear to us all that GA is the commonest cause of poor vision in people over 50. And so I don't think we need to argue that it's not a problem, which is what we heard from Suzanne. And the fact that the trials don't show a loss of vision is indicative of how slow the disease is, not that the disease does not cause loss of vision. And I think, unfortunately, the trials, because of feasibility and cost, have been short. And if only they had been longer. And I think, as your slide shows, that if we get into the 3rd year, you get to see more compelling evidence that indeed there is functional preservation. And the idea that we can't even bother to look at it because it's post hoc, I think, is flawed. I think the trial was randomized. The patients did the study when they were randomized. The only thing that was post hoc was the intelligent looking at the functional outcomes. We've got to remember these trials were designed years ago, and we know much better now as to how better to look at the microperimetry. And I think we're seeing from the data that there really is preservation of retinal function. So I think if you believe that we are saving cells, which is what the FDA wanted, then you have to have this available to patients. And then it's just an individual discussion with the patient about risks and benefits. And because we see thousands of people with GA signing up for trials where they don't know any risks and any benefits, they clearly want some treatment. And so I think it's reasonable, I would tell Australia to approve the drug, and then it's a decision between me and the patient, knowing the risks and the benefits, to work out who should have it and who shouldn't. I'd like to see that the atrophy was due to AMD. I don't want to have inherited retinal diseases, so I think that's very important to make sure we take our time to diagnose there's GA. I'd like to see that there's growth, so we do have time to have imaging at one time point and then come back and show evidence of growth. And then I would think it's reasonable to have that discussion with the patient.
Very good. Okay, let's move on to another topic that we just heard Frank talk about. And so this is for Ted, Bob, and then I'm going to ask Emily a follow-up. So, you know, here we have a patient we're following. We're trying to figure out, are they really getting worse? And then if we're treating them, what metrics are we going to use? We have this Heidelberg system, which is very intensive. We have some of the newer AI systems. But let's start with you, Bob. You're seeing patients. Let's say you treat some patients. What systems are you using, your approach, and what would you like to have in your clinic if you're thinking about treating these patients with GA?
Thank you, Karl. Well, you know, the beauty of being in private practice and just doing that one-on-one with the patient, you don't have to follow any protocol. You can look at the whole picture, and Frank Holtz listed a lot of the, you know, ways in which we pick out the patient that's going to progress the fastest and benefit the most. And so I go back and look at the photos. If I have photos, I pick the patients that I think will progress the fastest. And I see this picture here from AI from Vienna, and I don't have that. I wish I had that, but I do think there's in the paper that came out just a couple months ago from Ursula's group, it really shows that you can look at the ellipsoid zone loss or the photoreceptor loss versus the RPE loss and really predict the progression rate at the one time point, predict it if you don't have photos from before, and also the response rate. So I look at the EZ zone, and like in this patient here, I don't see much EZ zone in the middle in the foveal area, even though there's no GA there. So I think this would be a patient that I'd be likely to treat because it's going to end up having a lot of EZ loss probably if I could use the AI. And so I try to tailor the treatment just to the patients I think are going to progress the fastest, and hopefully using AI in the future will be much more precise with that.
Great. Ted, your thoughts?
Thanks again for inviting me on this panel, Karl. I agree with Bob. You know, seeing patients, there's certainly an unmet need for a treatment for this condition. I think just to add to what he's saying, you know, having a way to predict using AI potentially what's going to happen in the future, pre-treatment, and then while they're under treatment to see what if there is a change in the trajectory of their vision in their eye is the best way to kind of reassure patients that treatment's actually doing something. Because I think the real challenges with these treatments is, you know, we have this great body of data from the clinical trials, but in reality, it's hard to show some substantial, tangible evidence of treatment effect when we're actually in the room with our patients. And so I think having some predictive technology is great.
So now to you, Emily. You know, the AREDS is such a rich source of data. You gave us, you know, the simplified approach in intermediate AMD. Any thoughts about how you can use that beautiful data to help these folks in the clinic trying to accelerate their decision-making process?
And thank you again, Karl. Yes, I think all of these are actually covered by others already. I think AREDS 2 and AREDS 1 are very important data sets because of natural longitudinal data that we have. We are somewhat limited because we had color photographs only in one data set, but the other has OCTs and other things that are really important, especially OCT and fundus autofluorescence images. And we've actually have done some work, NORALAD and others have used this to do the AI work, which has been added by Justin Earlers and as well as Ursula Schmidt. So those are really important factors. And we found, similar to what Frank has found in his data set, that those characteristics that we can actually see, such as bilaterality, bifocal, non-foveal, those tend to be much faster progressors. So those are important aspects to look at. And then going back to the AI, I think a number of people have actually brought this to to fruition, but now the CCOI, which is the collaborative community on what used to be called imaging, is now innovation, is actually looking at how to bring some of those to actually clinical practice as well as the clinical trials. So we're looking forward to using some of that because it is difficult, as we say, looking at a patient, but looking at the history and what we know about the characteristics, and that's hopefully the AREDS 1 and AREDS 2 will help with that in the future.
Fantastic. So we're going to move on just to a quick kind of case study, and this is GA in the setting of CNV, and this is for Ted and Bob. First question. Would you treat these patients, or do you treat these patients? And again, similarly, your decision-making in the context of both an anti-VEGF and potentially an anti-complement inhibitor. Maybe Bob will start with, or maybe Ted will start with you first.
Sure, thank you so much. I think this presents a real-world challenge that we often face now that we have these agents available in our offices. Patients that present with long-standing exudative AMD and then develop new areas of atrophy that are visually significant. So this particular patient of mine did notice a scotoma in their vision, and so you have to have these discussions about what you should do in these situations. This also presents a logistical challenge. What dosing regimen are you going to use if you do decide to do anti-complement therapy? Are you going to do Q4, Q8, somewhere in between? And how do you schedule those visits, whether you're doing them on the same day or you're alternating weeks and then that patient's coming in quite often to your office. So I think these discussions are very individual. I present them with the data and my opinions, and certainly it's usually driven whether to start these treatments based on the patient's level of concern. Maybe Bob, do you have any experience with this as well?
Sure. I mean, I view this as this lesion looks like geographic atrophy rather than the macular atrophy you get around a regressing CNV lesion, which is more controversial because we don't have data that shows that those lesions respond to the complement inhibitors. But if this is typical GA, which it looks like in this one image, I would offer treatment if the patient is amenable. I would have the discussion with them. I don't treat a lot of patients who have concurrent CNV because of not having the data to back it up, and it's all about the risk-benefit ratio. And I want to find the patients that are going to go the fastest and have the most to save. And if they're not progressing and it's not something that I think is going to affect their vision, then I'm less likely to recommend it. But if this patient has a noticeable scotoma, and it's growing, I would offer treatment.
Okay, fantastic. Let's move on again, and this is Emily for you because we just heard this, really exciting stuff from you all, Tiarnan and everyone. Maybe you can just talk about, he mentioned potentially an AREDS 3 program. I mean, this is really, it is retrospective data, obviously. And your thoughts, maybe you can just explain a little bit more on what you all are thinking about this data and how best to kind of leverage it as we go forward.
Well, as you mentioned, AREDS 1 and AREDS 2 is a very longitudinal study with a lot of data in that. And what you heard Keenan did was really quite remarkable because we always thought that AREDS supplement was only good for neovascular AMD. Although we never said you shouldn't take it because we know that GA patients also develop neovascularization. So there should be actually a combination would be very helpful. We also looked at diet, and diet tend to be very important for reducing particularly geographic atrophy. So a combination of diet and supplement might be very important. And obviously this data is post-hoc analysis, so very interested in looking at a prospective study to see whether we can prove that, and that's really important to do. So we are actually in the process of negotiating and thinking about doing an AREDS 3, which is very exciting for us. One component would be to look at patients with geographic atrophy, and the design will be very interesting to see how we would go forward longitudinally to study this. What would you use as your standard of care, for example, and how would you test that? So that would be one component. But the other component is looking at early AMD and some of the intermediate AMD, whether we could reduce early AMD going to intermediate AMD. If we can do prevention, that is a great thing to do rather than waiting till the very end and giving these intravitreal injections. Looking for something that might be oral and easy to take and hopefully not too expensive. So those are all things that we are considering. We're going to do a series of workshops to actually work on that, but we're really very much thinking about this and also incorporating AI in some of this as well too, thinking how we move forward. I think, there's a lot of interesting things. The technology is so great. For example, we're thinking that we'd like to get OCTs as frequent as possible, but these are patients with very early disease. Could we do some home OCTs at occasional and watch that through rather than bringing them to the clinic? So there are a lot of interesting things that we like to look at, and so very excited that this may happen.
Fantastic. So we're going to end with just a little discussion about intermediate AMD and where are we in terms of trying to figure out, Emily, you just talked about potentially trying to treat earlier. Maybe we'll start, Robyn, with your approach in terms of what you've been doing with various groups as it relates to intermediate AMD, trying to figure out how could we structure trials to figure out and what would be appropriate endpoints as we think about treating earlier in this disease.
Yeah, terrific. This is, of course, where we all want to get. So I think we're at a unique time in our history where we have the granularity of understanding the anatomy with the OCTs and the FDA having moved slightly on their endpoints, that we're now at a position where we can actually design a pragmatic, feasible intermediate AMD trial. It's not because we've not ever had ideas of what to do, it's just how would we convince pharma to go ahead and do a trial. So at the RIMA meeting this year, Group 2, that Glenn Jaffe and I led, we actually came up with our best guess clinical trial design for intermediate AMD, which should be published soon. And in that, we considered what the FDA has currently said, and it seems that they're much more like a slope of change rather than an onset of an incident endpoint. So whilst we had been thinking about the onset perhaps of an atrophic endpoint like C-RORA, or in our case, nascent GA, or some endpoint, it doesn't seem like the FDA is there yet. They want to see a slope of growth. And they have moved on the EZ line and also the hypertransmission, the large hypertransmission defects. And so in our trial design, in this activity that we did with RIMA this year, they were our two co-primary endpoints, one looking really at photoreceptor survival and the other RPE survival. So that was our trial design. And I think whilst there's still a lot to learn about how those two biomarkers behave and the natural history is important, at least it gives us an industry somewhere to go so we don't lose this initiative and this interest in trying to intervene early. So I think it's a very exciting time that we do have something that we can propose.
Great. And so, Joan, why don't you follow up then, because again, we are thinking purely about anatomy, right? But are there other things that we should be thinking about as it relates to intermediate AMD? Because in some ways, many of our outcomes that we just looked at are very RP specific. And where do we stand with photoreceptors and trying to understand in intermediate AMD, what is the role of the disease in their function, since function is such an important outcome? Your thoughts?
Yeah, thanks, Karl. And I guess Robyn and I could have an arm wrestling over structure versus function. But I think there's lots of exciting areas to learn, and she wants to go. We'll talk to the program coordinators. I am a fan of function, and I think that's what our patients care about. And I think in the intermediate AMD space, there are really opportunities there. And again, the QCSF, which you've got up here, the quantitative contrast sensitivity, seems to be a useful marker, as well as some of our other functional tests like low luminance visual acuity and reading speed, but really to show an effect on the patient's function, which is going to translate to an intervention that helps them in their quality of life. And that really is what we ultimately care about.
Right. So it may be, less filling, better, more taste. Yeah. So we may have to have an arm wrestling match next time. But again, I want to thank all of the panelists for their insights and then for their willingness to discuss their perspectives on these various topics that we've covered today. And again, I want to thank the organizers for allowing us to speak today. Thank you so much.